Right. Hi, I'm Abby Phelps, and this is my third video, and we will be going over drug therapy for COPD patients. So maintenance therapy, kind of like what we went over in the last video, group A to group D. So group A, which is your less symptomatic, low risk, short-acting bronchodilators, as your SABA and your SAMA are needed for symptom relief. Group B, more symptomatic, low risk, long-acting bronchodilator, such as their LABA or LAMA for regular symptom control. Group C, which is less symptomatic, high risk, long-acting agonist LAMAs to reduce exacerbation risk. Group D, more symptomatic, high risk, such as your LAMA, preferred as initial therapy, or LABA/LAMA combination, or inhaled corticosteroids, such as your ICS/LABA combination. You can consider if blood eosinophils are elevated, suggesting a potential steroid response. So maintenance therapy. So initial maintenance for less severe COPD. We're just going to go more into detail now. So those are your as needed short-acting bronchodilators, such as your SAMAs. In early stages, which is called A, patient may need a SABA like albuterol or a SAMBA like idatropium for occasional symptom relief. The focus is on relieving acute breathlessness. Then we have our progression to long-acting bronchodilators, which can be your LABAs/LAMAs. So these are your increased symptoms as COPD progresses. Symptoms like breathlessness and activity limitation become more persistent. Then your long-acting bronchodilators are introduced. So your LABAs, such as salmeterol or formoterol, provide sustained bronchodilation, which improves airflow and reduces symptoms throughout the day. For LAMAs, those also provide long-lasting bronchodilation and can particularly be effective at reducing exacerbations. So why add LABA or LAMAs? These medications offer longer lasting relief than SAMBAs and SAMAs, leading to better symptom control and improved quality of life. They're used regularly, not just as needed. So then we get into adding inhaled corticosteroids. So these are for frequent exacerbations, which can be gold C or D, and or asthma overlap. IS are not a first-line treatment for all COPD patients. They are typically added when patients are experiencing frequent exacerbations, 2 or more moderate exacerbations per year, or one leading to hospitalization. There's evidence of asthma component to their COPD. This might be suggested by a history of asthma, significant reversibility on spirometry, or elevated blood eosinophil counts. So why ICS? They reduce airway inflammation, which can help prevent exacerbations. However, they also carry risk for pneumonia, so they are used selectively. Combination therapies, so inadequate control with single agents, so many patients will require combination therapy to achieve optimal symptom control and reduce exacerbation risk. So there's your LABA/LAMA combinations, which provide bronchodilation, often more effective than either agent alone. And then ICS/LABA combinations Those address both bronchodilation and airway inflammation in patients with frequent exacerbations or asthma overlap. Very rarely, we'll do triple therapy. But this may be considered for patients with severe COPD, frequent exacerbations despite other treatments, and or evidence of asthma overlap. So things to consider when you're giving your ICS treatment. Like I said, pneumonia is a factor. So you need to understand the underlying inflammation and the mucus production of your COPD patients. You need to consider the risk factors. So their age, smoking history, and exposure to risk factors. And then their signs and symptoms. So pay attention to symptoms like chronic cough, sputum production, and recurrent lower respiratory tract infections.